Disease or stones in the gallbladder, or what is called as cholelithiasis, is quite a common problem. It is often said that it is more common in women, which is true. It does happen in people over the age of 40, in fertile female who are usually fat. But that doesn't mean men are exempt. Men get gallbladder stones quite often as well. And unfortunately, men have much worse gallstone disease. We do not exactly understand why, but this is anecdotally said around the world. Patients with gallbladder stone disease end up having stones that form in their gallbladder because of multiple reasons. This can be primarily because of what is called a supersaturation of bile, at which point the gallbladder is not doing what it is supposed to do and ends up concentrating bile into a stone rather than remaining in a liquid form. Patients with gallbladder stones are diagnosed either incidentally when they're having an ultrasound scan in a regular health checkup, or they can present symptomatically. Patients have symptoms of abdominal pain, which is primarily on the right side and in the upper quadrant, and patients can have other symptoms such as jaundice, fever, or a variety of combinations of the above. In my practice, I often say that the abdomen is a Pandora's box, and patients can present with gallstones with none of the symptoms that I've mentioned before, and can have completely unrelated symptoms as well. It is very important that when we're dealing with patients who've got gallstone disease, we've also made sure that they've had an endoscopy to make sure that they do not have any other causes for dyspepsia that may be masquerading as gallstone disease. Now, when it comes to gallstone disease, not everything is the same. We classify them as three groups: patients who have biliary colic, patients who've got acute cholecystitis, and patients who've got chronic cholecystitis. All these three conditions are different, they present differently, and they're also treated in a slightly different manner. A question that I often get asked is that I've got gallstones, what do I do with it? I'm not entirely sure, I've got symptoms from it. Now, what I say to those patients is that you see a specialist GI surgeon who's got an experience in this field with expertise, and they will be able to tell you whether your symptoms are attributable to gallstones or not. If they think that your symptoms are not attributable to gallstones, they will be able to offer you other investigations to check and ensure that you've not got any other red herring symptoms that are presenting as gallbladder stones. Even in those who do not have any symptoms of gallbladder disease, there is a justification to suggest that you have this treated electively in a select set of patients. My general rule of thumb is that if you expect to live for about 20 years at the time of diagnosis of your gallstones, I would recommend that you have your gallbladder removed, because that would likely prevent further complications from gallbladder disease. The complications of gallbladder disease could be pain, could be pancreatitis, because the pancreas can get inflamed. They could have jaundice because a stone slips from the gallbladder, goes into the bile duct and gets blocked there. That can further lead to cholangitis. Patients who've got gallbladder disease that is ongoing and recurrent can have thickened gallbladder walls that can become gangrenous over a period of time or can perforate. The gold standard treatment for gallstone disease has remained a laparoscopic cholecystectomy for the last few decades. We are well past the phase where we did big cuts on the abdomen to remove a gallbladder. We now place only 3 or 4 small keyhole cuts on the abdomen, and we're able to safely remove the gallbladder. Gallbladder surgery technique has also evolved over a period of time, where we now use what is called as a posterior window first approach, where we create a critical window of safety to ensure that the gallbladder is removed carefully, making sure that the biliary tract is not disturbed. When done by a trained surgeon in the art of cholecystectomy, patients often have very good results. The incidence of bile duct injury has been falling over the last few years, and we are now at levels that are significantly lower than what it used to be, let's say 2 decades ago. Techniques have improved. We've had better results outside of the surgery itself, where we are preparing patients better for the operation. We've got better perioperative care. We've got enhanced recovery principles that we've introduced in our practice. And in certain places, we are able to do gallbladder surgeries in a day case manner as well. Patients who have gallstones should definitely see a GI surgeon with an interest in gallstone disease, so that you can discuss your condition and get what treatment is right for you. With the advent of robotic surgery, now there is a push to getting robotic surgery into the gallbladder space as well, and it will likely be the future of treating this as well. I often get asked this question: can you not just remove the gallstone and leave the gallbladder behind because it's an organ? I often say to these patients, you've got the gallstone because the gallbladder isn't doing its job. So you would rather not keep an organ that's not functioning to its optimum capacity, wherein it can actually become more problematic than it is worth. In only a few patients who are frail, elderly, comorbid, who will not tolerate an operation, is when we just drain the gallbladder or attempt to remove the stone. But for the large majority of patients, a gallbladder surgery that is done laparoscopically or robotically by trained surgeons is a very safe procedure. Most patients can go home within a day or two after their operation and are relieved of their symptoms almost entirely when done correctly.